So in the next 45 minutes or so, we're going to try to put everything together. And what I mean by that is all the concepts that we talked about, local therapy and systemic therapy. This is actually where we kind of bring that information to the bedside, where we actually talk about, in an interdisciplinary way, what we call a tumor board, our patients and how we apply all the therapies. And so I just want to introduce a couple of new people on the panel here. So Dr. Patel is going to be our, our radiologist extraordinaire. And I'm just going to, this is his bio. Dr. Patel graduated from South Gujarat University, India in 1988, completed his residency training in Gujarat University, India in 1992. He was a tutor in radiology and later assistant professor of radiology in India before opening his private practice. After immigrating to the United States, he did his residency in radiology at St. Francis Hospital in Evanston, Illinois in 2006 and completed his fellowship in MRI training from Proscan Imaging in Cincinnati, Ohio. Dr. Patel has authored or co-authored more than 20 publications in peer-reviewed journals and more than 65 educational exhibits, during which he mentored radiology residents and fellows. Currently, he is working as an editor on a book in musculoskeletal anatomy. He's a board-certified radiologist and is interested in all facets of musculoskeletal radiology, including interventional muscularadiology and ultrasound in musculoskeletal radiology. He is dedicated to improving patient care and is true to the core values of Keck Medicine of USC. And apart from his clinical work and administrative duties, he loves teaching residents and fellows at USC. So that's Dakesh, and he will be, Dr. Patel, he will be our radiologist. Dr. Chopra, on the other end, stand up and take a bow, okay. Shefali is assistant professor of clinical pathology at the Department of Pathology at Keck Medical Center at USC. She was an attending pathologist at Cedars-Sinai across the way. From 2012 to 2014, she did her fellowship, let's see here. She received her medical degree from King George's Medical College in India, and you did some training at Memorial Sloan, or excuse me, at MD Anderson. Okay, I just wanted to get that one in there as well. Okay, so with that, let's go ahead and get into our cases. Let's see here. So the first case, and we're going to try to go through 3 cases with 15 minutes each. So the first case is the case of a 28-year-old male with myxoid liposarcoma of the left posterior thigh. He noticed the mass approximately 2 years prior to consultation with slow growth. In July 2018, he had an MRI of the left thigh, and this demonstrated a 22-centimeter mass in the left posterior thigh, so big mass in the left posterior thigh. Biopsy at an outside hospital showed a low-grade myxoid liposarcoma, and he was subsequently referred to USC for further management and treatment. Okay, advance. So, Dr. Patel, could you go over the previous MRIs for us?
Yes, so these are the 2 MRIs that the patient had. The top row is the MRI that was done without contrast on July 3, and the lower row is the one that was done with contrast on July 17. And as you can see over here, this area which you see is like grayish and then very bright over here. That is the patient's tumor, and it extends on the back of the thigh as well as on the back of the knee, which is the popliteal fossa. After giving contrast material, you see that this tumor enhances. That's the tumor again there. And next slide, please. Okay. And the important thing over here is that we look for what happens to the neurovascular structure. So that's the femoral artery over there. And you can see that it's separate from the tumor where there's a preserved fat plane. But here is the actual sciatic nerve, which over here you can see that the tumor is like about 180 degrees surrounding that particular nerve. So that raises a suspicion that the nerve may be involved with the tumor. There is no bone marrow or bone abnormality. That means the tumor is separate from the bone.
Okay.
Next slide.
Next slide.
So as a part of the workup of this particular tumor, the patient had a CT scan of the abdomen and pelvis, and that did not show any additional metastatic disease.
Okay. Okay.
We didn't have the outside slide, but we did have access to the report, and that was called a myxoid liposarcoma. There was no round cell component seen on that biopsy, and the
Sheffield.
DDI fish was positive.
Mike.
Share that. Okay.
So the we didn't have access to the outside slides, but the biopsy was called a myxoid liposarcoma. There were no round cell components seen on the biopsy, and the DDIT3 fish was reported to be positive on that.
Okay.
That's it.
Okay, so this is the discussion part. Let's see. Dr. Chopra, what's the significance of a round cell component in a myxoid liposarcoma?
So a round cell component signifies a higher grade, and those have a worse prognosis as opposed to regular myxoid liposarcomas, which are mostly FNLCC grade 1.
Okay. And so this kind of fits that natural history, as he discovered this about 2 years ago. So biologically, it seems to be, or clinically acting very, very slowly. So it kind of fits that. Dr. Singh or Dr. Menendez, are there any issues about surgical resection for this patient? And I can go back to the slide if I can do this. Yeah. The MRI slide. Any issues about resectability on this patient?
So the neurovascular bundle is not encased with the tumor, but it's right on it. So you know any margin you get here is going to be basically lousy unless you take those, which we don't generally do. So it's curious that we'll accept the marginal margin along the neurovascular bundle any day of the week, but we get all uptight about how many centimeters there are through the muscle and so forth. Mm-hmm. But in terms of taking it out, it's pretty straightforward.
So it's resectable?
Yeah, and I mean, I agree with what Dr. Menendez said. It's resectable, but those structures are very close. In fact, Dr. Patel was pointing out that the sciatic nerve is it's encased. Right?
It's partially.
Yeah, partially encased. So, and that for the people in the audience that is a major morbidity if you injure that sciatic nerve. So it's an important consideration when you're thinking about whether it be when you're thinking about surgery on this patient.
Okay. Dr. Ragab, what do you think? Can you do? Are these radiosensitive, and can we at least help maybe shrink the tumor to get a better result?
Yeah, so for myxoid liposarcoma, that's one of the few sarcomas that actually does shrink with radiation, so it might help with resection. In that this patient actually presented to an outside academic center in a different state and was actually redirected by his insurance to me somehow, so this sort of plays into what we talked about. So he had to come from out of state, and his first point of contact was here with me. So he was anxious to start the radiation because he had been recommended to have radiation before surgery at the former institution. So we kind of followed that model here.
Okay. So I'll go and ask myself this question. I'm the medical oncologist on this board. Is there any role for systemic therapy in low-grade myxoid liposarcomas? And the answer is we generally don't treat low-grade sarcomas with systemic therapy. If there was a round cell component, we would consider treating that with a doxorubicin-based therapy or something called Yondelis, a relatively new FDA-approved drug for a round cell myxoid liposarcoma. So I think we have a consensus with the panel that we're going to try to treat this with radiation therapy first, followed by surgical resection. Okay. So that's special recommendations. Let's see how this works. Okay. Dr. Raghav, can you explain your radiation fields?
Yeah, so this patient came in to see me, and I planned him for neoadjuvant radiation, meaning radiation before the surgery. So like I said during my talk, very often our recommendation is 50 gray before surgery, 60 gray after, so it's a higher dose. So that's what gets presented at the tumor board. And so it seems like a simple decision, but in fact, most of the art of radiation isn't, the dose that you're going to give, which we tend to standardize. We're sort of a very standardized field. It's how do you want to get that dose in. So for this patient, we decided to do 3D radiation, which if you remember from my talk, is sort of the simplest of them. Some people come in saying, I want IMRT, I want something more complex. When in actuality for this patient, and we'll see on the next slide, is that the 3D radiation is actually the best for him because it's going to spare more of his normal tissue because we can just treat it with 2 lateral fields that will go through the posterior thigh but avoid the anterior thigh. So that'll minimize his toxicity in terms of the skin because we're only radiating basically the back half, as well as lymphedema, which is a backup of blood flow and lymph after surgery and radiation treatments.
Okay.
So on the next slide, so this is sort of what the final plan looks like for his radiation. We did talk about fertility preservation in this patient as one of the, we had a question about that earlier. So I offered him sperm banking ahead of time. The chance of like permanent sterility in him is very, very low, but because there is some distance, but I did counsel him on it and offered him sperm banking. And then you can see, so on the top left corner is the knee joint. So I was trying to spare the knee joint as much as possible here. So we were able to exclude most of the knee joint from the radiation field, which will also minimize toxicity from the radiation in terms of like early arthritis. And then this is one last view, and you can see that we're able to spare part of the knee there, as well as a small amount of skin. You don't have to spare a lot of skin. Just sparing a little bit makes a huge difference in terms of risk of edema in that leg.
Okay, so he received 5 weeks of radiation therapy?
Yeah, 5 weeks of radiation, and then was sent for resection.
Okay.
So these are the patient's images after the radiation therapy, and as you can see, this is the tumor which has shrunk markedly, and this is actually the examination after administration of intravenous contrast. And unlike the previous, where we saw a lot of enhancement within the tumor, you can see that most of the tumor is not enhancing. There's a very small portion that is enhancing. So that is a good response as far as radiology is concerned.
How big would you say that is right now after the radiation? It was 22 to start off with, and
Right. This came down to about like 14 centimeters.
14 centimeters. Okay. So, Dr. Menendez, you did surgery on this gentleman, and can you explain what you might have found or what your plan was for surgery?
So, the patient obviously had a very good response to the radiation. And maybe just one comment on that. It's a little unusual. Most of the time, when you treat with radiation, you don't get any response in terms of the size of the tumor. These are tumors of connective tissue, they don't shrink the way hematologic cancers do and so forth. So this is a little unusual, but good. The closest margin was the nerve, which we had talked about earlier. And the hope is that with the surgical adjuvant, that being the radiation, that it'll keep the rate of local recurrence very low. And so all in all, I think the surgery went fine and no problems. And then he's going to need
Great.
follow-up,
Awesome.
obviously.
So we took out a 15-centimeter tumor. Looks like you felt really good about the margins. And so here's the pathology specimen Shefali, can you comment on that from the resection?
So this is what most of the tumor looked like after the treatment effect, and you can see there's a lot of, like most of it is all pink and doesn't have that many nucleoli. There were very few foci of residual tumor, and this is what a myxoid liposarcoma would look like. They have these lipoblasts, they have these vessels which define the tumor, and this myxoid background. So most, like 95% of the tumor, approximately 95% of the tumor just looked like this. It had this fibrosis/hyalinization. Can we go to the next slide?
Sure.
So the tumor, so this was called a myxoid liposarcoma with marked therapy effect, approximately 95% fibrosis/hyalinization. The tumor actually measured 14.6 centimeters at the gross bench. The margins of resection were free of tumor, and again, there were no round cell components seen.
Okay, great. So great result, and you should be cured in over 50%, 70% of cases, you would say. So any questions on our management with this patient? Yeah.
Could you, it's great presentation. Could the panel comment a little bit on post-op functionality, what you expect long-term in terms of lower extremity function, and what sort of rehab, you begin when you do it, and those issues?
So the question always is whether you give preoperative or postoperative radiation. And so, generally surgeons like postoperative radiation. And the reason is we don't have to deal with as many wound complications and so forth. It's true that they get more radiation over a larger field, but, surgeons are selfish sometimes. They just care about the wound complications. But the biggest, in terms of the nerve, is no problem now. You expect fibrosis and scarring, so generally you're going to see decreased range of motion over time because the radiation effects lag quite a long time. You could also, in the future, look, he didn't get that much radiation, but you could look to get a neuropraxia even 5 years later. And then in terms of the bone, you can get radiation osteitis, which can lead to pathologic fracture and so forth. But certainly in the short term, he functions perfectly normally.
Thanks. Okay. Any other questions? I thought I saw a hand there.
I've got a question. So this is a funny tumor, the myxoid liposarcomas. They can metastasize unusual areas. What about the prospect of giving some of these patients, even though it's low grade, some kind of systemic therapy with Undalis or something of that nature? We just had a long discussion about treating something that's completely benign, aggressive fibromatosis, with systemic therapy. This is a tumor that can kill somebody and has an unusual pattern of metastatic spread. So I'd ask you, do you think there's a role for
U.S.?
Yes.
Yeah, no, it's a good question. I'd be
Sure.
be interested to hear your thoughts as well. But at least from a surgical standpoint, it's a very large tumor, and you could always make the argument that the lack of a round cell component, the high grade, may be a sampling error. Although sometimes, on radiology, you might be able to get a hint that there may be an area to target for biopsy to see if there's a round cell component. But it's such a large tumor, there could be a sampling error. In fact, data from MD Anderson series shows that even in presumably large, low-grade myxoid liposarcomas, large just like in this case, they somehow metastasize. It's probably a missed round cell component. Dr. Hu did bring up a very good point, though, that biologically, clinically, this patient had this mass growing for 2 years. So that speaks against a high-grade round cell component. It speaks more towards a less aggressive, low low-grade tumor. From a surgical standpoint, I don't see any disadvantage to giving neoadjuvant systemic therapy. So in this situation, and this wasn't my patient, of course, it was yours, Dr. Menendez, but I would not have been opposed to giving systemic therapy ahead of time, neoadjuvant, along with the radiation.
So these are some of the discussions that we have at Tumor Board. And sometimes, the role of adjuvant systemic therapy or systemic therapy after the tumor is taken out is really controversial as to the benefit. And so, as you can see, these are relatively rare tumors. And so as a result, you're not going to get a large randomized study to detect a small difference. So the data is just not out there. So, and we know the limitations of the data. But having said that, so we have to really base our recommendations on the prognosis of the patient. And even if there's a small benefit, let's say a 5% benefit overall in patients, really the prognosis dictates what we do. And so if you can download an app onto for you sarcomatologists out there, you can download this app. I think that was my cue to use this app, right? Okay. And so download this app onto your iPhone. And it's called a Sarculator. And what that'll do is it'll give you a prognosis based upon the age, the size of the tumor, the grade of the tumor, and the extremity versus retroperitoneum. And so I just plugged those numbers in, and you can see that the 5-year overall survival would be 92%. So if you've got a small benefit of chemotherapy, it wouldn't be a very large benefit relative to a 92% overall prognosis at 5 years. So in a patient who had a 50% chance of surviving 5 years, I might consider adding systemic therapy on top of that. Now, you bring up another point, the role of early or neoadjuvant therapy to try to shrink the tumor. I think, Will, you talked about that paper from MD Anderson, in which low-grade liposarcomas do respond to chemotherapy, to doxorubicin-based chemotherapy. And so that could have been a modality if a resection was an issue, if organ preservation or preserving the sciatic nerve was an issue. We could have certainly added systemic therapy to improve the outcome, the functional outcome later on. So that's sort of the discussion we always typically have.
I think it really depends on the histologic subtype too, and this is one that's, as I said in my talk, it's very sensitive to both radiation and certain forms of systemic therapy. Also, you balance the toxicity of whatever Dr. Hu wants to give to the patient. And so there are a lot of considerations when thinking about neoadjuvant therapy. There's no, I will say that there is no data that says that neoadjuvant compared to adjuvant is any better or worse. It's the same outcome. There's differences in terms of wound complication rate, as Dr. Menendez alluded to, but in terms of outcome, neoadjuvant versus adjuvant is, as far as we can tell, there's no great data to say we favor one or the other. So it's very individualized.
Yep.
Knowing that you have a marginal margin at the sciatic nerve and the vascular bundle, in the preoperative planning, what would you plan with the margin
At the muscle. So if it were my case, I would essentially resect the visible, the gross tumor and the muscle that it looks like it's arising from the muscle or within the muscle. So I would take that tumor and get gross negative margins. I don't think there's a need to do an entire compartmental resection, but I didn't see the entire scan.
Okay, yep, go ahead.
This is a different aspect of this management of this unusual tumor. When a tumor is growing very slowly like this, in 2 years it grew, but not did not kill the patient. And then this kind of slow-growing tumor, how long do you think that when tumor cell, this patient's tumor cell begins to proliferate at the beginning, whether it was a 2 or 3 cell count to 100, 6,000 cell count to grow this big. I feel that probably took many years to grow this size. Then, do you have any idea, slow growing tumor like this, how long does it take to be detectable?
Yeah, that's a great question, and I think Dr. Hellman tried to answer that question earlier on. But I can tell you that for these low-grade, we just had a case of a low-grade myxoid liposarcoma, who it was a patient who, boy, I think we treated him at 32, and he had a mass that he detected when he was 18 years old, and in fact, he decided to get it looked at and have surgery when he couldn't put his pants on anymore. Over the tumor. And so when we got him, we were actually able to resect it completely. So I could tell you that, at least from our experience, at least 14 years from the time of detection of his lump to the time that we did his surgery is the duration that a tumor can stay indolent for that period of time. So yeah, I don't know if I have an answer to your question, but for a low-grade myxoid liposarcoma, it can be very, very indolent and can be there for a long, long time.
And I just wanted to add that it also depends on the part of the body. One of the diseases that I see very frequently is liposarcoma in the retroperitoneum, in the retroperitoneum, which is the back of the abdomen. And sometimes these tumors, much greater than 22, they could be 40 centimeters, 50 centimeters. One of the tumors I resected was 77 pounds. And the reason that they get to such a large size is because it develops in the back of the abdomen where the kidneys are. It keeps on growing slowly over time. We don't know for how long, and it doesn't come to the attention of the patient or doctors until it gets to such a large size. So that exact same tumor, if it were on the patient's, let's say the wrist or something like that, it would probably grow 2 to 3 centimeters and the patient would go see their doctor right away. And it can be the exact same disease is my point.
Okay, let's go on to the next case. We have a couple of cases here to go. So the next case is the case of a 31-year-old male with a Ewing sarcoma, diagnosed at the T11, thoracic spine, with metastatic disease to the lung. He initially presented with back pain to an outside emergency room in June of 2018. He had some neurological symptoms and also some bladder symptoms. He then underwent an emergent surgery for a potential cord compression at an outside hospital. His initial diagnosis at the outside hospital was an ependymoma, and he was therefore referred to USC Neuro-Oncology Department for evaluation. So he was subsequently seen by USC Medical Oncology for consultation in July 2018. So that's the case presentation. Okay. So
this is the patient's initial MRI at the time of presentation. It was done at the outside institute. What we can see over here is this particular vertebral body, which has got abnormal marrow signal. And then adjacent to that, you can see this tumor, which is going within the spinal canal, which is just outside the layers of the spinal cord. So we call it as an epidural space. And then on this image, you can see that there is also a component which is growing within the muscles. So the tumor is growing on the inner side of the spinal canal as well as on the outer side of that vertebral body. And then the whole of that vertebral body in that region is also affected. So the tumor is involving the left side of the vertebral body, pedicle, lamina, and the spinous process, which is that portion of the vertebral body. The patient on the same day also had a CT scan of the abdomen and pelvis, and we include portions of the lower lungs when we do the CT scan of the abdomen and pelvis, which showed that patient has one lung nodule in the right lung base and then another lung nodule in the left lung base. Just based on the presence of the nodules and the presence of this epidural mass, we always think that this is most likely going to be metastatic disease.
So this is at the time of his surgical resection, his CT scan was done. Okay. Okay, can we review the path from the outside hospital?
So we got the slides from the outside hospital, and you can see this tumor was in Ness, and it's composed of these round cells which are very uniform. There are some mitotic figures, but not a whole lot of pleomorphism. Can we go to the next slide? So a lot of immunostains were done, and most importantly, the keratins, the S100 and the Desmin were negative. And the CD99 showed this nice membranous staining, which is kind of characteristic of this tumor. So CD99 is pretty non-specific, can stain a lot of tumors, but once it's this diffuse and membranous, it kind of helps you with the diagnosis. And the EWSR1 FISH was performed, and it showed the break apart at the translocation. The most common fusion partner is the FLY1, and then the next common is the ERG, and then there are 3-4 less common fusion partners. Can you go to the next slide? So this is an Ewing sarcoma, and the negative immunos are listed there.
Okay. Okay. Discussion and recommendations. So this gentleman presented us with with metastatic Ewing sarcoma, and the primary modality of therapy for this, as you heard from Leo's talk, is chemotherapy. And so I would recommend chemotherapy for this gentleman after adequate staging, which included a PET scan, which is coming up here in a second. Okay. Okay, Dukesh, can you go over the...
So this was at the time of initial presentation, and this is approximately about 2 to 3 weeks after that as a part of the staging PET-CT. And these are the CT images from the PET-CT portion, which shows that the lung nodule in the right lung, as well as that in the left lung, both of them have increased in size. That means the tumor is progressing. And next slide, please. And this is the rest of the PET-CT, which showed that there was no other additional focus of metastatic disease. This increased activity that we see over here in the back, that is all just related to the recent surgery. So this is just inflammation related to the surgery and not actually from the tumor itself.
How about the lung? Any uptake in the lung at all? Or is it too small to see?
Yeah, the lung nodules they were less than 1 centimeter, and PET scan is not really that good for detection of metabolic activity in the lung nodules. So it's the limitation of the PET scan to detect metabolic activity within the lung nodule unless it's really, really very high metabolic activity.
Okay. So how about radiation oncology? Is there any role for radiation in this patient?
Yeah, so at the initial surgery, the tumor was decompressed as much as was possible, but because it was pressing on the spinal cord, it wasn't felt that the surgeons could get a complete resection. Ewing sarcoma, like I mentioned in my talk, is one of the few sarcomas where radiation can be used as the definitive therapy. So that's what we elected to do here. So this is a sample of the patient plan, one slice. So like I said before, so the high dose is the red here, and you can see the rapid dose fall off from red to blue as we get full away. So this is an IMRT plan that we used. And then you can also see, it's a little bit hard maybe, but in the middle here is the spinal cord that I highlighted in red here. So that's what we're trying to protect. So if you overdose the spinal cord, that can lead to permanent paralysis or other definitely worrisome toxicities. So this is the one structure that we protect at all costs. So you can see how it's a little bit greenish here in the middle. So basically the full radiation dose is skipping just this very small area. So you can imagine why setup is so important here. If you set this patient up 1 centimeter off, now that spinal cord is getting the full dose and will exceed its tolerance. So that's why we have to be very, very careful with treatments such as this.
Okay.
This is another view of the same thing. So this is a sagittal view. And basically, you can see that we're extending the high dose to include that vertebral body that we thought was involved on the PET scan, as well as all the other imaging, as well as the posterior elements. So a lot of this tumor was sort of behind the vertebral bodies. So we covered all of that, anything that was positive on the PET scan, plus a margin that we use. So everything that we treat, we don't just treat what we can see because we know it can be, a centimeter outside of that. So we use safety margins. So this includes that safety margin.
Good. So, let's see, is this post-treatment? Yeah, so we went ahead and started him on chemotherapy with VAC-IE given every 2 weeks with the hope of rendering a complete response and possibly interdigitating a radiation therapy after around the 4th to the 6th cycle. These are some of the results that we have.
So these are the images following chemotherapy, and as you can see over here, that was the size of the nodule before they started the chemotherapy, and this is the size which has considerably decreased. On the opposite side, that nodule is no longer seen. Next slide.
Okay. Next slide. Okay. Omar, in a patient with metastatic disease, Ewing's sarcoma to the lung, is there any options for radiation to the lung?
Yeah, so after the patient finished all of the chemotherapy, all 14 cycles, we still address the lungs here. We know from older studies that there is data that people will still recur in the lung even if you don't see anything. So we still do whole lung radiation therapy for patients. So this is this patient's whole lung radiation therapy plan. And this was also actually done with IMRT. That's not really the standard. Usually do it with 3D conformal radiation because, like I said, the lungs are expanding and moving in and out and doing all sorts of things. So usually you want a big open field. You don't want it to be surrounding the lungs so conformally. The issue with this patient is T11 is, you can't really see it here, but it's right behind the heart back here. So remember, we had maxed out the spinal cord dose to try to cure the primary disease. So the only way to get the dose to the lungs is to carve it around the spinal cord even more. So essentially the patient's spinal cord got no dose from this radiation, which is pretty amazing when you think about it, even though it's right behind what we're trying to treat. So we had to use IMRT, and we had the patient actually hold his breath during the treatment because I was so tight on all of these margins that if I opened everything up to have him free breathe, and this went up and down, I was going to miss lung. So that's how complex a lot of these sarcomas can get. Even though, like I said, we just say 50 gray at every tumor board, the way we deliver that is really the art of radiation oncology.
Okay, great.
This is just a similar sort of map with the high dose in red and then the lower dose going on from there.
Would you have done RT full on had there not been metastatic disease?
No, so we only do it if there is metastatic disease. It's not done for prophylaxis.
And knowing the original lesion at T11, unless it was a proven progressive neurologic deficit, do you think that there would be anyone who could make a case for radiation therapy since the wound is so sensitive without surgery? And had they done surgery, would there have been able to put in any kind of a gold foil or anything further protectable?
So the second question is putting in something to block the radiation. So this radiation is so strong that you have to put in like 10 feet of lead to block it. So nothing that you put in the body is going to help. We don't have patients wear lead shields like you do when you go to the dentist because it's going to go through that lead. So we just can't. There's not much we can do about that. But for the first question, so we do definitive radiation for these because the surgeon can't get it all out. Surgery, as far as we know, has slightly better outcomes if you can get it all out. But we brought this up at our tumor boards as well, is that there's a bias there because the patients who get definitive radiation tend to be the ones with the biggest tumors in the worst locations. So inherently, they're probably going to have worse outcomes. We just don't really know. But But the reason that this patient got surgery before he came to us is that it was pressing on the spinal cord and causing some neurologic deficits. So you want to relieve that obstruction as soon as possible and then get the patient to curative therapy. So, so that was the right thing to do at that time.
Yeah, it was an emergent cord compression. That's why they did the surgery. Okay, so,
James, can I just make a comment on that?
sure.
So this is, this is sort of an emergency when a patient presents in the community, but in this day and age might be managed slightly differently if the patient came to an academic center. So, if somebody presented with a tumor, paraspinal tumor with a vertebral body involvement, and this was clearly, extra axial and not a CNS tumor, the leading diagnosis is Ewing sarcoma over here. And Ewing sarcoma is very chemosensitive. More than 95% of them respond to chemotherapy. And if we had a patient like this, we would have just started with a tiny biopsy and had a small round blue cell tumor, and it was CD99 positive, and for an extra bit of measure was NKX2.2 positive, which usually indicates an underlying EWS translocation. We would have started this patient with chemotherapy right away, because surgery is almost, will never get clear margins and can actually add to morbidity in the patient and a delay in initiating therapy. So we would probably start with this patient chemotherapy. In my experience, the risk for cord compression and neurological deficits just disappears. And even if it's mild neurological deficits, these patients usually recover completely. It's only after you have a dense involvement that there's a problem. And I agree that definitive radiation therapy is the treatment of choice for the management of this particular patient.
Thanks, Leo. You want to come up here? So anyway, this gentleman received 14 cycles of dose-dense chemotherapy every 2 weeks. He got it on time all the way through to his 14th cycle. And even interspersing the radiation therapy, he still got everything on time. In fact, he was a little ahead of schedule. So, okay, so he received all 14 cycles without delays and his radiation therapy, and these are the results. This is his follow-up scans.
So this is part of the routine surveillance scan. So this is a PET scan, and the whole PET scan was essentially negative. The activity that we saw in the spine, it has all dissolved. Next slide.
Okay.
And then this is the images from the local region. You can just see the post-therapeutic changes, those following surgery and radiation, but there was no tumor recurrence.
Okay. Questions, comments? We're going to try to move. Okay. One question.
I have a question. So, if the patient if the patient is presented with two options, so how can they decide? Like, do the chemo or do the surgery? Because he said he's going to start with chemo, and then they said they do the surgery to relieve the patient from the difficulties.
So chemotherapy would be the sort of the primary therapy for this gentleman. Now, as far as the surgical resection portion, it's a little bit more difficult issue because it's in the spine. And so I kind of defer to our surgeons and our radiation oncologists as to whether they can resect or not. But as Leo mentioned, typically it's hard to get a nice margin on a spinal tumor where the primary is in the spine. And so he's going to get radiation therapy anyway, and radiation is definitive and potentially curable. So we probably...
Because we had a relative that, this similar situation. So two oncologists gave her two different options. First, start with chemo, and then the other one started with, do the surgery. So the patient didn't know which one was a more, prudent
Right.
or wise approach to her.
So
Can I address that for a minute?
Sure.
And this is the reason why you need to have a multidisciplinary expert team, and you actually present a consensus recommendation to the patient. So we would have had the surgeon, the oncologist, and the radiation therapist all aligned around that recommendation. And so the recommendation would have been one recommendation rather than giving a patient a choice of doing this or that. Because truly the patient's not in a position to really make that decision and choose between one or the other. And so that's the importance of teamwork and nothing really there.
Okay. Okay, so we've got a few minutes to go over the next case. And the final case, this is a 32-year-old female with an alveolar soft part sarcoma of the right humerus with metastatic disease to the lung, brain, and soft tissue mass, and a soft tissue mass lateral to the right hilum. She underwent resection of the right humerus, mass at an outside hospital with fixation, and received stereotactic radiation therapy to the brain. She was then referred to USC Medical Oncology for a clinical trial. Can we review the radiology, Bruce?
So these are the x-rays from the time of presentation, and they were done at outside institute. You can see some mottling over here, which we call radiological as a permeative pattern, and it is destroying part of the cortex, that is the outer shell of bone. So this has a very aggressive appearance, and radiologically this is concerning for either a primary neoplasm or a metastatic disease. Next slide.
Okay.
The patient also had an MRI at an outside institute, which shows the extent of that tumor within the proximal humerus. These are the fluid-sensitive sequence, that is after injection of contrast material intravenously. And you can also see on this one, the black is the outer shell of the bone, and the tumor is already destroying that and is trying to come out of that particular bone. As part of the workup, the patient also had a CT scan of the abdomen and pelvis at that time, and these are some of the representative images. So at the point, the arrows are pointing towards these lung masses, which are in both the sides of the lung, so the right and the left lung. And then the patient had additional mass. One was here on the right side of the pelvis. This is a cross section. This is the long section. And then there was an additional mass, which was also on the left side of the pelvis, deep to this muscle, and it is eroding the bone over here. So based on this, we know that the patient had at least multiple lesions, one in the humerus, multiple within the lungs, one in the subcutaneous tissue on the right side, and then one over here affecting the bone.
Can we review the pathology?
So these were the slides from the outside, from the curettage and the bone biopsy. And you can see that this tumor is arranged in nests, and it has this vascular surrounded by these vessels. And the tumors themselves, there's again not a whole lot of pleomorphism, abundant cytoplasm, vesicular nuclei, not a lot of mitosis, which kind of defines this tumor. And then sometimes when the tumors, they can have a pseudo-alveolar pattern too, but this tumor doesn't. Can we go to the next slide? So there is, this tumor has a translocation of the TFE3 on the X chromosome with the ASPL on chromosome 17, and so there is an immunostain which marks for it. So the TFE3 immunostain was reported to show strong diffuse nuclear positivity, and which kind of would support the diagnosis. And other than that, a whole lot of immunostains like the pancytokeratin, desmin, S100, HMB45, SMA, PAX8, inhibin, melanase were negative. Because the histological differential diagnosis on this case would be like a renal cell carcinoma, a paraganglioma, a melanoma. The surgical resection, okay, this is, so.
Okay.
So this is from the resection. So the resection was again performed on the outside, and then you can see the tumor looked similar. It again had these cells arranged in these nests with abundant cytoplasm, not a whole lot of mitosis. There's one mitosis in this field. Can we go to the next slide? And the margin was reported, the distal marrow margin was negative, and the tumor size was 4 centimeters, and it involved the proximal humeral shaft. and there was a soft tissue component on this tumor, and the closest margin was the peripheral margin, which was 0.2 centimeter. The distal margin was quite far, it was 6.5.
Okay, so an extremely rare tumor, alveolar soft part sarcoma, that's metastatic to brain, lung, bone, and so the question of, Dr. Hu, is there any systemic therapies for this? The answer is there has been some data, some small studies looking at the use of tyrosine kinase inhibitors in this. One study looking at cediranib that showed some response, although albeit fairly small, as well as sunitinib as well. Most of these studies came from Europe. However, in alveolar soft part sarcoma that's metastatic, we really don't have any good systemic therapies. And so at this point, we recommended going on a clinical trial with a new immune therapy known as an anti-PD-L1 inhibitor. So she was enrolled on the clinical trial. And if you can go over.
So actually, these are the images before the patient went onto the clinical trial, when the patient was receiving standard therapy. And these are the serial images from the MRI of the brain. And as you can see, that tumor had continued to increase in size even during that standard therapy that was a patient receiving. Next slide, please. And these are the sets of images from the CT scan of the abdominal pelvis. The extreme left are the initial scans, and these are the follow-up during that standard therapy. And you can see those tumors, they have continued to increase in size. This one too has become larger, and that smaller lesion here in the left side of the pelvis has often also become large there. At the time of that surveillance, we found out that the patient had another tumor which was near the pancreas, and then we went back and looked at it, and there was a small one in that region, very difficult to see, but when we measured it, it has again increased in size. So it all means is that the patient, when was on the standard therapy, the tumor continued to go and did not respond to the therapy.
Oh, okay. So the patient was started on immunotherapy. Sorry about that. I jumped the gun a little bit. With atezolizumab and anti-PD-L1 immunotherapy. This was started in February 2018. So post-therapy follow-up?
So here are the sets of images which are from the CT scan of the abdominal pelvis and also on the brain later on. And over here you can see this is on February 26. And then this is approximately 1.5 months later on. And this is at about 3 months following the start of the therapy. And you can see that the tumor has started to shrink really fast. And this is the last follow-up where you can barely see anything, but probably just some scar tissue. Next slide, please. The lesion that was near the pancreas also slowly disappeared. And on the last images, you don't even recognize where it was. Next slide, please. These are the lung masses. As you can see, most of the lung masses have near completely disappeared or have become extremely small. Next slide. And this is the brain metastasis, which has also become extremely small in size and is barely visible there. So there is a dramatic response that we see as far as the decrease in size is concerned.
So you can see that's a fairly recent MRI, February 2019, and a really good response with atezolizumab in an ASPS, and that's why you go on clinical trials. Any questions? I know we're kind of running a little behind. Please. Okay. Okay, good.
I had a couple questions. On this last case, with the immunotherapy treatments, how long would you expect to see that work for? I know I've just had experience with a lot of patients where it only works for a very short period of time.
Sure, sure. You know, I think the question is still out there. This is a small study. There's still accruing patients. Mm-hmm. They just expanded the cohort to include another 30 or 40 patients. So it's reopened for ASPS patients. But from the, we're hoping at least from the melanoma literature, you know, that those patients essentially can be cured. There's actually a plateau on the survival curve. And so, at least for ASPS, we're not sure what the long-term durability is, but we're very hopeful.
Did the clinical trial require PDL or PD-1 testing?
No, it didn't.
What do you think about it?
Well, as you know, it's sort of a mixed bag. It's really just lung cancer that seems to be predictive for PD-L1 expression and response to immunotherapy. In melanoma, for example, it's not always predictive, right, of a response to immunotherapy. But you know, in sarcomas, just kind of in general, we've been doing a lot of immune therapies. In fact, we did one of the first trials here using pembrolizumab, the SARC-28 study, and some of the data is going to be presented at this year's ASCO meeting. But what we found is, so the design of that study was 10 cohorts of patients, including Ewing sarcoma, and basically they were all high-grade sarcomas. And the only real one that had a signal was the pleomorphic undifferentiated sarcomas. So I'll just kind of let that out right now, okay? So you guys are ahead of the game here. But there was about a 40% response rate in those patients. Now we'll have to go look at that data a little bit closer. But it did seem that PD-L1 expression was important in that cohort of patients.
So,
Okay.
can I ask one more question?
Sure.
Okay, last question. Is the most common question that I get asked from people and their families is this idea of like chemo before therapy, chemo before surgery, radiation before surgery or radiation after surgery, and they are being seen at like centers with extensive research and tumor boards, but it doesn't seem that they truly do get that kind of answer, that it seems like it is up to choice, and the recommendation seems to differ from sarcoma center to sarcoma center. So I mean, I'm not a doctor, but a lot of, especially with high grade and liposarcomas, we get this question all the time. And so I didn't know if if anyone can just comment on like the way that you would guide people. It's like, this doctor told me this doctor told me this, both excellent institutions. One prefers the radiation before surgery, one prefers the radiation after, but it will hold them up for weeks trying to decide who to go to. So I would just like to hear an opinion on that.
Well,
so I can try to address it. I don't think it's going to be a satisfactory answer because there is no satisfactory answer. But I can give you an example of a patient that I saw for the second time last week, and this patient saw 5 or 6 radiation oncologists trying to decide whether or not to get adjuvant radiation. I had said, I don't think you need it, but he just kind of saw, and they were all big academic centers in Southern California, and he saw 5 people and got 5 different opinions. And then he like circled back to me and was like, what should I do? And I was like, I don't know. Like, who do you trust more? But what I told him in the end is that if you got 5 opinions, that means that there's no right answer. And there isn't always a right answer for us. And what I told him is ultimately it's your choice. But if half the people told you get it and half the people told you didn't, then you can see 1,000 RADONCs and you're not going to get one answer. But that case is a little bit different than maybe the case that Dr. Mascarenas was talking about, where like we have one recommendation. And so I think like the concept of paternalism in medicine and saying like do this or don't do this is real. But like sometimes it makes sense for us to say, hey, do this because we know it's the right thing to do. Like you wouldn't tell your pilot how to fly your plane. If you're telling them, then you shouldn't be on that plane, right? You should go somewhere else. But sometimes there isn't a right answer, and I can tell you do this or do this is probably okay either way. So I think, we have to have that discussion between us and patients, and sometimes we have to be forceful, and sometimes we have to say, make your choice. And both ways work for some people, and some people get upset either way, and we just have to learn how to work together on that.
So the thing with the radiation, if you count all the live bodies afterwards, there's no difference whether they get pre or post. But the complications are different. So it's really up to the patient to decide what complication they feel they want to deal with. So, I mean, yeah, so the surgeons will say, yeah, I don't, you give the radiation afterwards, so I don't have to worry about the wound. But then the patient has more to worry about in terms of stiffness and the fibrosis and the nerve and this, that, and the other. If you give it beforehand, they could wind up with a wound infection, a flap. They have to delay their chemotherapy. They may have to have an amputation because of that infection. And you can't predict nobody has a crystal ball. So I think the patients need to make the choice sometimes. You could say, well, I prefer to do this because, but at the end of the day, it's not the radiation therapist or the surgeon that takes the risk, it's the patient.
Thank you. Well, we're going to keep going. So basically, there's the summary of our cases. Low-grade localized sarcomas treated primarily with local therapy for the low-grade ones. Ewing sarcoma primarily treated with chemotherapy with the addition of radiation and or surgery interspersed within the chemotherapy. And then metastatic sarcoma is the mainstay of treatment is systemic therapy and clinical trials as well. So I'll just kind of leave those generalizations there. And I'd like to thank the panel for coming up here and handling this very, very complex tumor board. And thanks for your attention.